Good morning. When I was invited to give a talk at the World GI here at ESMO, I thought it was going to be a challenge because there's a lot of literature on the basic research and clinical research done in hereditary colon cancer syndromes. And what I wanted to do today is actually, following Goethe's statement, trying to make a bridge between this evidence-based medicine and how can we make a connection with our routine or clinical-based medicine, and how can we really be aware about these hereditary colon cancer syndromes, what can we do to identify them and actually give them the adequate recommendation surveillance in order to decrease the incidence by colorectal cancer. And that's what I'm going to try to do in the next 20 minutes. If we go back 100 years ago, in 1913, Dr. Worthen was a famous pathologist who was approached by his seamstress because she was concerned about her risk of dying of cancer. She had a family history of colon, gastric, and endometrial cancer, and she really thought she was going to die of cancer. And actually, at the age of 36, she passed away with a metastatic endometrial cancer, and he couldn't do anything else but just publishing and making the community aware that there was a family cancer predisposition. How this scenario has changed in 100 years, we may still be approached by patients talking about their family history, but also we can find in our clinical practice that in a pathology report, we may have for instance, a case of a 43-year-old patient with a stage 2 right-sided colorectal cancer who underwent a right hemicolectomy. And the pathology report states that her tumor had microsatellite instability and loss of MLH1 protein expression. The patient reports a family history also of endometrial cancer, and she's seeking advice to find out if her children must undergo surveillance with colonoscopy. And these are my questions to the audience. Do you think this is a clinical suspicion of a hereditary cancer syndrome? If so, what other molecular or genetic tests would you recommend to her in order to identify this genetic susceptibility? And finally, may the result modify the future colonic and extracolonic surveillance in her and her close family members? How are we going to address all this, and how are we going to communicate these recommendations to the rest of the family? So first, I would like to bring you a picture of the prevalence of hereditary colorectal cancer syndromes. We could summarize that approximately 10% of all colorectal cancers that we see in our clinics are related with a genetic predisposition. The most common one is the Lynch syndrome that accounts for approximately 3% of all the colorectal cancer syndromes, and it is related with 4 genes. We have individuals that look like Lynch syndrome, but they do not have mismatch repair deficiency. We're still calling them familial X syndrome. And then we have a collection of polyposis syndrome. The most common one is familial adenomatous polyposis and attenuated familial adenomatous polyposis. We're going to talk about them. They are related with APC and MYH mutations. And then we have hamartomatous polyps. And finally, this year it has been described some germline mutations in POLD1 and POL1, the DNA polymerase genes that explain a family history of young-age colorectal cancer, adenomas, endometrial, and brain tumors, and we have some data about this new genetic syndrome. If we focus on Lynch syndrome and the prior case report that we saw, this was a 43-year-old woman who had microsatellite instability and loss of expression of MLH1. We first should know that microsatellite instability can approximately represent 10 to 15% of sporadic colorectal cancer, and that this is mainly due to somatic tumor mutation because of the promoter methylation of MLH1. And this is highly correlated with the BRAF mutation V600E. When we look at the meta-analysis published last year in 2012, and look at individuals who are mutation carriers and have a BRAF mutation, we see a very weak correlation among these two molecular results. But if we go down to the last row and look at individuals who are not germline mutation carriers of any of the Lynch syndrome genes, but still have microsatellite instability and loss of expression of MLH1, we can see that 63% do have a BRAF mutation. So, just as a rule of thumb, but if we have an individual with no family history, microsatellite instability, loss of expression of MLH1, and we do find a BRAF somatic mutation, we are quite sure that this individual would have an sporadic tumor and not a germline mutation in MLH1. It's not only tumor molecular screening that helps us identify these individuals. Classically, we have been recognizing them because of fulfillment of clinical criteria. Tumor molecular screening is based upon microsatellite instability and immunohistochemistry, and there are also some clinical prediction models that estimate the likelihood of finding a mutation based upon the personal and family history, and they provide a likelihood of either 5 or more than 10% in order to pursue germline genetic testing. If we go to family history and try to find out if these individuals fulfill some clinical criteria, doesn't matter the specialty of the physician. There are some evidence that we are not very good in taking good family history, and in some cases, only 15% of us are taking a good family history, and even if they fulfill these individuals' clinical criteria for Lynch syndrome, only 1/4 of them will be referred to a genetic service in order to pursue more profound genetic evaluation. So it seems that clinical criteria, maybe because of time burden, may not be useful to select these individuals. And in the last years, it has become more and more common, and there's a big number of publications in the literature that tumor molecular screening performed universally in colorectal cancer patients might be a more easy way to approach individuals and identify those who are related with Lynch syndrome. Very recently, meta-analysis, a pool analysis of 4 population-based cohorts with more than 10,000 individuals with colorectal cancer, analyzed the sensitivity and specificity of different tumor molecular screening approaches. And the authors concluded that doing microsatellite instability or immunohistochemistry in those individuals with colorectal cancer who are younger than 70 years, or those who are older and fulfill any of the Bethesda criteria, so there is a first or second degree relative with colorectal or endometrial cancer, has a very high sensitivity. 95% of mutation carriers are in these 2 scenarios. Specificity is also very high, and compared to universal approach, it might be a little bit better because there will be less individuals that will have to undergo molecular testing and also germline analysis, so that it could be a cheaper approach compared to universal screening. So ESMO has actually endorsed this algorithm, and recently we did publish the algorithm of testing individuals who are younger than 70 or those who are older and fulfill the Bethesda guidelines and perform immunohistochemistry or MSI. If it is abnormal and the abnormality comes from loss of expression of MLH1, we should rule out an sporadic cause by doing somatic BRAF mutation or MLH1 hypermethylation. And if it is positive, we would stop there. If it is negative or there is loss of any other protein, such as MSH2, MSH6, or PMS2, we would pursue germline genetic analysis. So how is this being done now in our clinical practice? This is a picture of last year in the United States, and we can see the difference between National Cancer Institute hospitals and community hospitals. This tumor molecular approach is being done in approximately 70% of these research hospitals, while in more common hospitals where we are working, either if they are cancer or hospital cancer programs, only between 15 and 30% of these hospitals are doing microsatellite instability or immunohistochemistry. So it is time, I think, to bring all this evidence base from the research setting into the clinical practice, and we should start requesting our laboratory departments, our pathology departments, to pursue either microsatellite instability or immunohistochemistry. What are the challenges? What are the clinical challenges? Why aren't we doing this? There are several questions. First, should a patient write and concern before doing a microsatellite instability or immunohistochemistry? It is actually a somatic test. It's not a germline test, but it gives you some information about the susceptibility. Second, who will be interpreting and disclosing the molecular screening results? Who's going to be these physicians? Who's going to take the responsibility? And finally, what will be the patient's uptake for referral recommendation to a specialized high-risk clinics? These are the challenges that in our clinics we will be facing and coping in order to make this a reality and identifying as many individuals as we can. And this has actually been approached in a very recent paper of our colleagues in Australia. And I'm sorry for those who are surgeons from Australia, because they didn't do a very good role in this project. The investigators here recruited 245 patients with mismatch repair deficient colorectal cancer from a population-based cohort. And these individuals were seen by the surgeons, and if they had this mismatch repair deficient tumor, the surgeons were sent a package advice recommending them to tell their patients to be referred to a genetic service. Unfortunately, only 55% of these individuals with a high priority likelihood of Lynch syndrome actually undertook germline genetic testing. They had not been convinced by their physicians of the importance of undergoing germline genetic testing. And also, in a research basis, all these individuals consented for a research testing. And only 13% of these patients actually also declined to receive results of testing. So there is also the right not to know, and there seems to be some population who do not want to know there is a genetic susceptibility for this defined type of cancer. So overall, despite having a universal molecular approach that it seems to be very sensitive, still an estimated 5% of mutation carriers were missed, and that means that 1/3 of Lynch syndrome cases here were actually missed despite using the most research-based, more efficient screening approach. So actually, if we go back to the first slide, it seems that really putting all our ideas into action is the most difficult thing in the world. We really need to make a connection between all this evidence-based medicine and find now, when we put it into our practice, what are the real barriers that we are facing, and try to definitely convince our patients about the importance of knowing if there's a germline susceptibility, and based upon the next knowledge and information that I will be providing you now. First, individuals with Lynch syndrome do carry a very high risk of developing colorectal, endometrial, and ovarian cancer mainly. And this high risk actually appears at the very young ages and much younger than in the general population. As we can see in these graphs, at the age of 50, men may carry up to almost a 20% risk of developing colorectal cancer. And women at the age of 50 may also carry as much as a 10% risk of endometrial cancer and a 5% risk of ovarian cancer. In addition, these individuals do have a faster malignization process, and from adenoma to carcinoma, it may take a much shorter time than in the general population, and it might be as short as 1 to 3 years. And colorectal cancer tends to appear in the right colon. Therefore, colonoscopy will be really necessary in order to detect this colorectal cancer at an early stage. If we look at the projects that have tried to tell us the efficacy of colorectal cancer surveillance in Lynch syndrome patients, we see that in the Finnish population, after a 15-year follow-up of individuals who were all mutation carriers and those who decided to pursue a screening every 3 years versus those who didn't do a screening every 3 years, we can see that after 15 years there was a 62% decrease in colorectal cancer incidence, and that this also translated in a 65% decrease in mortality. Some other studies later on with a 98% compliance rate still are showing us that there might be some interval cancers, and that at the age of 60, as much as a 35% of colorectal cancer can still develop. Shortening the intervals of the colonoscopies every 2 years also helps to delay the age at colorectal cancer diagnosis, but still interval cancers appear in between these intervals. And this has finally led to recommending colonoscopy every 1, maximum 2 years in individuals who are mutation carriers starting at the age of 25, and there is no upper limit age, and it will depend on other comorbidities. And I would like you to spend just some few minutes in this slide, because I think despite not being a direct comparison, which is not valid, but if we look at the efficacy of doing a preventive approach in Lynch syndrome patients in order to reduce colorectal cancer mortality, we can see from the Harbinen, the Finnish study, that those who underwent colonoscopy every 3 years versus those who didn't, their risk of dying by colorectal cancer decreased by 65%. If we then go to other graphs, you know, the benefit of giving FOLFOX4 versus 5-FU leucovorin in the adjuvant setting in individuals with colorectal cancer also had a beautiful hazard ratio of decrease in mortality of 0.80, a 20% decrease in mortality, but this is in the magnitude of months. It's no longer in the magnitude of years. And also in the metastatic setting, a beautiful result just presented at ASCO 2013 that the addition of panitumumab to a FOLFOX4 in individuals with a wild-type KRAS also decreased colorectal cancer mortality, but again, we are still in the magnitude of months and not years. So I think it is worth to think about the really decreasing mortality that we can achieve by identifying these high-risk individuals and giving them the appropriate recommendations. Do these individuals adhere to colorectal cancer surveillance? Not really. From these research projects, we can see that as much as 40% of them may not adhere to the adequate recommendations, and that's why interval cancers appear. But do we also have clinical predictors in order to increase this adherence to surveillance, which is really pursuing germline genetic testing, a young age diagnosis, and actually making a results disclosure and a medical report and telling the patient to report these results to the referral physician and being also followed by a high-risk clinics. So I think it is worth to have a genetic service close to your clinics and help pursue all these surveillance recommendations and pursuing germline genetic testing, which will increase adherence to the surveillance. And here we have actually that in the Finnish registry, with a 96% compliance, we have the results of the surveillance of mutation-positive patients versus non-carriers. And despite having a very high risk ratio of developing colorectal cancer, with surveillance, there was no impact on overall colorectal cancer death rate and cancer mortality rate. It is also important that the new advances in technology for surveillance of these individuals can be applied, and actually chromoendoscopy has shown to be very effective and sensitive. It increases the number of adenomas. It is especially sensitive for flat adenomas and also for all those lesions that are proximal to hepatic flexure. And finally, Dr. Arut will talk more about this, but there is some chemoprevention that can be done and given with aspirin. In this randomized placebo-controlled trial, it was shown that aspirin for more than 2 years at a dose of 600 milligrams per day could decrease by 65% the risk of colorectal cancer and also other Lynch syndrome-associated cancers such as endometrial, urinary tract, and gastric cancer. If we then move gears just a little bit to the most important hereditary polyposis syndromes, the first one is familial adenomatous polyposis. This is an autosomal dominant disorder. It is also important to note that 30% of mutation carriers will be de novo mutations. They will not have a family history. This is being presented by more than 100 or 1,000 polyps scattered along the colon with a very young onset at appearance. There is a 100% risk of developing colorectal cancer if a prophylactic colectomy is not done before the age of 40 and 50. And there might be some extracolonic manifestations such as duodenal adenomas, hepatoblastoma at a very young age, papillary thyroid carcinoma and desmoid tumors, and even brain tumor. MYH-associated polyposis, it's an autosomal recessive disorder. 80% of mutations in the Caucasian populations are located in 2 hotspots, and it is characterized by multiple colorectal adenomas, usually less than 1,000, and the frequency of MYH biallelic mutations, there must be 2 mutations in the germline, is between 2% and 7%, depending on the number of polyps. These individuals do also carry a very high risk of developing colorectal cancer, almost 100% risk if polyps are not being taken or even prophylactic colectomy is being done. And there is also a need for surveillance of the duodenum because there's an increased risk of adenomas that may finally become malignant. Our recommendation in terms of doing germline genetic testing is to consider the pattern of inheritance. If it's a dominant family history or it's a de novo presentation with a classical phenotype, more than 1,000, we would recommend pursuing APC germline analysis first. And if it's a recessive, so there's no so the family history, it's only in the same generation, but there are in parents, there are polyps, no colorectal cancer, or it's a de novo presentation with an attenuated phenotype, we would recommend to pursue MYH first. Finally, this syndrome has recently been described and published in Nature Genetics from the group of Tomlinson, based upon different family histories of individuals who had a dominant pattern of young onset colorectal cancer, endometrial cancer, and even brain tumor, and some with multiple adenomas. They didn't have microsatellite instability, they didn't have MYH mutations, APC, they didn't have Lynch syndrome. And actually, these individuals were carrying a mutation in the DNA polymerase genes, POL or POLD1. And these mutations were actually affecting the proofreading activity of these proteins so that the fidelity of the DNA polymerase couldn't be done adequately. Compared to individuals with Lynch syndrome, these individuals do not have microsatellite instability, but they do have a very potent mutator phenotype and even chromosomal instability. And I hope that in the next years we will have a more clear picture of the risk of developing cancer and the prevalence of these genes in hereditary colorectal cancer syndromes. And finally, I just want to give you one slide about the importance of the familial implications when we identify a genetic predisposition to colorectal cancer. And I think it is important that we consider that we have the duty to warn these individuals that this might be familiar and that a special surveillance recommendation should be pursued by their family members who might be at risk. So in conclusion, it is also important that we remember that cost-effectiveness of all these approaches will increase with the number of family members that are being tested for a germline susceptibility. And in the case of Lynch syndrome, when more than 3 individuals are being tested in the same family, cost-effectiveness is really very important. So finally, my take-home messages for this morning would be to call your attention to the awareness and action about Lynch syndrome and the polyposis-associated hereditary colorectal cancer syndromes. We can do universal molecular screening. We can do cancer prevention. This is possible. It decreases 65% the probability of having a colorectal cancer, and this impacts in also the mortality. There are strategies for Lynch syndrome identification that are cost-effective. We can do it in the private or in the public health systems. Finally, polyposis syndromes should all of them be genetically tested in order to decrease their high penetrance of developing colorectal cancer. And finally, let's remember to include recommendations to family members in our medical reports. Thank you very much for your attention.